But right now, talking about treating fillers, or in fact, treating filler complications with hyaluronidase. Please welcome Dr. Shaheen Dollie.
Thank you very much, Liz. Thank you, FACDC, for inviting me. Thank all of you for waking up early and giving up your Friday. Thanks, Dr. Chris, for a good presentation. Dr. Susan, for the lovely demonstration and talk on anatomy. It's the basis of everything we do. Today, I'm talking about hyaluronidase. That's Nelspruit Airport, in case you're wondering. Smallest, prettiest, and probably most expensive airport to fly to or from in the country, from which I hail. Now, hyaluronidase, as I'm alluding to, the dreaded ally, is not truly dreadful in itself, merely the situations in which it might be required. Go forth. Right, I have no disclosures to make or any financial statements. So he injected all of these substances into the dermis and looked at what spreads the furthest. And he found an extract from, the testicles of rats, as it were, but he named this the Francisco Duran Reynolds spreading factor. And this was, in fact, hyaluronidase. Right. So, in 1934, Carl Mayer, the German, together with his assistant John Palmer, looked at and managed to identify hyaluronic acid of bovine cows. This was, in fact, hyaluronic acid as we know today. Interestingly and curiously, Carl Mayer only discovered hyaluronic acid a few years after hyaluronidase was discovered. This is astounding stuff. This is kind of like finding antivenom for snake poisons and then discovering poisonous snakes. So very interesting, as the history would have it. Now, today we know that hyaluronidase is expressed, and there's a whole family of enzymes all over the body, from the eyes down into the bones, down into the reproductive organs. We know that it has a number of physiological functions. It's involved in wound healing. It's involved in embryogenesis. But we also know that it's involved in a good number of pathological processes, such as neoplasm formation and basically the formation of metastases and spreads of cancers. The ophthalmologists were ahead of their times. Back in 1940s, they were already harnessing the ability of hyaluronidase to spread tissues. They were doing retrobulbar blocks, and it conferred their advantage. They could use a lower amount of the anesthetic agent, and it conferred the advantage of a lower rise in the intraocular pressure when they were doing these procedures. Today, of course, we have a wide range of things that we can use hyaluronidase for. We use it in hypodermoclysis, which is the subcutaneous infusion of fluids. We use it as an alternative mechanism of delivering immunoglobulins. It's used in fertility medicine, and one day soon we hope that it will be a good marker for malignancies and following the spread of cancers. Go. Of course, in aesthetic medicine, front and center, what we're using it for is preventing ischemia from turning into necrosis. The most dreaded of them all, of course, is central retinal artery occlusion. And this is pretty much where hyaluronidase works. Now, we know that hyaluronidase works. It works incredibly well in the in vitro and in the in vivo circumstances. So hyaluronidase, it lyses and hydrolyzes the hyaluron-NAN bonds between each other. This is my stubby hands putting hyaluronidase on some HA filler, and it literally acts within seconds, and it continues to have its action over the next 24 hours. In the ex vivo test tube circumstances, you can see that it really takes a very short period of time to turn that gel into something which is a lot less viscous, more fluid, and we would hope that your body can then move that filler further along the vasculature, resupplying the area, reversing ischemia, preventing necrosis. And that's essentially what we're really trying to do. We're all safe doctors, of course, and dentists, so we hope we don't get into the circumstances, but hyaluronidase is there to be your ally in these circumstances. Now, We have a plethora of studies, and the literature has case studies and bigger studies, and all of them show that even in the in vivo circumstances within the human body in itself, hyaluronidase is just as effective, if not quite as fast, at lysing and getting rid of these hyaluronic acid boluses that's causing your obstruction. When we are not entirely familiar with the substance and a medication, sometimes we worry about the safety of it in terms of hypersensitivity, allergies, and anaphylaxis. And right in the beginning, this really was a big concern. Way back in the 40s and 50s, we were harnessing hyaluronidase from ovine and bovine origins. It wasn't the most purified of substances, so anaphylaxis was a little bit of a risk. Also, well, the ophthalmologists back then were using 1,500 units plus. They were using big amounts. It's good to note and keep in mind that Vespib venoms, bee stings, and wasp venom contain a high dose or a high amount of hyaluronidase. So if your patient is allergic to these, you might want to bear that in mind and weigh up your risk versus the benefits. Let's move on. Now, on the other side of things, Navarre and Sarnes took 25 volunteers, and they were looking at proving the spreading ability of hyaluronidase. They injected on the dorsum of the hands, 1% lidocaine on one side, and lidocaine mixed with a small amount, 7.5 units of hyaluronidase. Of note, well, they definitely proved that hyaluronidase spreads the stuff, but what was interesting was there was only localized erythema. None of the patients had anaphylaxis, none of them had wheals or flares, and this goes a far way to show that on the one hand you have higher doses of hyaluronidase with anaphylaxis, on the other you have a very small localized reaction. It supports the idea that the allergic response to hyaluronidase is somewhat dose-related and not necessarily an idiosyncratic reaction. I can't confirm that those were necessarily the guys that was part of the study. Now, today we have Hylenex, which is a human recombinant source of hyaluronidase. Unfortunately, we don't have it in South Africa. They didn't have it in Mumbai either, as it were. It's in the States. It's reported to have a hypersensitivity rate of less than 0.05%. It's incredibly low. There's been no reported case of true anaphylaxis. So if you do manage to get your hands on it, I'd recommend you use that. I cannot confirm nor deny that Hylenex is necessarily pulled out from little babies, but I'll leave that to your imagination. Right. The two circumstances which hyaluronidase would be necessary and you'd find yourself you'd be using it in. One is the emergent case of ischemia with impending necrosis and impending doom. The other is a little bit more relaxed, which is the elective cases of overfilling, Tyndall effect, a little bit of puffiness with venous obstruction, late or early formation of granulomatous formation. Now, in the elective arena, you have the time to do a test batch. The literature talks about 3 units all the way up to 20 units, but 3 units is generally what most authors have used. Injected intradermally, your patient is monitored for 5, 20, 25, 45 minutes. Most doctors would bring their patients back the following day to see if there's any late reaction. Localized erythema does not constitute a positive test. You need a wheal or a flare that occurs within 5 minutes that lasts at least 20 to 25 minutes. In that circumstance, you'd really have to think twice about whether you're going to go ahead and use hyaluronidase. Remember, this is elective. Most of the time, if you just wait, your hyaluronidase, your endogenous hyaluronidase, will get rid of the filler eventually. A little bit different if you have erythematous and inflammatory nodules and you're worried about infection and you're worried about a biofilm. In these circumstances, first start a course of antibiotics, then introduce the hyaluronidase, lest you cause and propagate a cellulitis. To further look at the doses, John Vartanian, the American plastic surgeon, took 12 participants, injected 0.2 mils of Restylane in 3 little aliquots. He then proceeded to administer hyaluronidase at 5 units, 10 units, 15 units, subsequently, respectively. Interesting. 2 things came from it. One was that in a number of patients, there was a dose-related response of localized erythema. The higher dose, bigger area, smaller dose, smaller area. The other thing that he noticed was that it doesn't matter what the dose of hyaluronidase was, it managed to lyse all of the HA. These are doses based on the literature, which is very inconsistent, but I think you can use them as guidelines. As a rule of thumb, for every 0.1 mil of HA, you're looking at 5 to 15 units of hyaluronidase. There is a difference in what HA you're using. If you're using a more particulate matter, lower concentration, lower cross-linking, such as something like Restylane, I hope I'm allowed to say product names, then you'd be using something like 5 units of hyaluronidase. If you have something like Voluma, higher concentration, more cross-linking, you're looking at about 15 units. So you kind of have to use your clinical acumen. There's no reported cases of doing repeated doses of low-dose hyaluronidase, bringing your patient back week after week until you get the effect that you want. There's no cases in the literature that says you're going to get sensitization to the hyaluronidase. Keep in mind that the tissues may become resistant when your patients are on a good number of various drugs, from antihistamines to vitamin C's to, if my slide will go along, there's a whole bunch of drugs, benzodiazepines. A lot of our patients are addicted to sleeping medication. So in these circumstances, you would probably have to use a higher dose of hyaluronidase. Right, those are the drug reactions. I'm moving swiftly along. Now, in the emergent arena, this is a completely different set of circumstances. Here we don't have the time to do an elective dose. I'm going to move further along fastly because we're running out of time, as much as in the emergency criteria. You would start out with a minimum of 200 units at a concentration anywhere between 50 to 200 units per mil. What that effectively means is 1,500 vial, because that's what's available in South Africa, draw it up to 10 mils, take 1.35 mils out, and then use that neat, draw it up to 2 mils, draw it up to 3 mils, depending on your area of lividity, your area of pallor, your area of ischemia. Monitor your patient for a good 20, 40 minutes. If there's no change, repeat the dose. If they're resistant, give a bigger dose. Yes? So you're taking your vial, 1,500 units. Add, and this is also a point of contention, saline or lidocaine. The thought process is lidocaine will cause vasodilation and improve your blood flow. If you're lucky, that's what happens. Not proven in the studies, but hopefully your patient's not allergic to lidocaine either. So 1,500 vial, draw it up to 10 mils. Take 1.3 mils of that out, and now you've got 200 mils, 200 units. Now, if your area is small, you can inject it neat. And you're injecting at 3 to 4 centimeters grid-like pattern through the skin. If the area is very large, you've got lividity, you've got pallor, you've got pain, which could be slight numbing, or it could be excruciating pain, then you're going to dilute that further into 2 mils or 3 mils or 4 mils to cover the area. Good question. Okay, I'm going to move very fast because I see I'm running out of time. So looking at the timing, the sooner the better. The study basically says that if injected within 4 hours in bunnies, it helps. At 24-hour period, it doesn't. Does it translate into humans? Well, we don't really know. Inject it as soon as you can. That's pretty much the rationale behind it. The last thing that I want to just say is the last study was by De Lorenzi, which showed that he took facial arteries, fish cadaveric, took a few of them, cut them up, tied them into little pieces, filled them with hyaluronic acid, chuck some into some saline, chuck others into hyaluronidase. And what he showed conclusively was that hyaluronidase has the ability to act transarterially. You don't necessarily have to cannulate the vessel you're trying to unblock. Just placing the hyaluronidase nearby, within that 3 to 4 centimeter grid, massage will get your hyaluronidase to act. And the very last thing I want to say is, if you don't have an ophthalmoplastic surgeon next door, which I don't have, it might be worthwhile looking at how to do a retrobulbar block. You can talk to me afterwards if you want to learn about the technique a little bit, in case of, God forbid, ocular symptoms. Thank you for your attention. Sorry for going over time.